Neuro-Oncology Fellow at the Aga Khan University Hospital. On behalf of the Pakistan Society of Neuro-Oncology, PASNO, I welcome you all. PASNO is organizing the Neuro-Oncology webinar series, and there will be a webinar in this series held every alternate Saturday. Each webinar is an hour long, where the speaker will have 30 minutes for the topic presentation, and then there will be an open discussion of 30 minutes between the speaker, Dr. Rashid Juma, Dr. Athar Inam, and the attendees. During the webinar, all participants will be muted to enable the speaker to present without any interruption. Questions can be submitted in the chat box and will be answered once the presenter has finished his talk. Participants can also raise their hands for questions. We will unmute them to enable them to ask their question themselves. This session will be recorded and the link will be shared on the PASNO website. Today, we are honored to have Dr. Asif Bashir in this session. The topic of his presentation is endoscopic resection of pituitary tumors, achieving hormonal cure and avoiding complications. Dr. Asif Bashir is an American board-certified neurosurgeon. Dr. Bashir received his medical degree from Pakistan's prestigious King Edward Medical College, now King Edward Medical University, in 1995. He completed his residency in neurosurgery at SUNY Upstate Medical University, New York, in 2007, and further went on to complete fellowships in complex spine surgery at SUNY Upstate and stereotactic and functional neurosurgery at Mayo Clinic. He was a professor of neurosurgery at the Seton Hall University School of Health and Medical Sciences at New Jersey by 2017. Afterwards, he returned to Pakistan and is currently heading the Punjab Institute of Neuroscience in Lahore and professor of neurosurgery. He is considered an expert in the field of minimally invasive surgery of the spine and brain. Dr. Asif Bashir, the floor is yours, sir.
Thank you for joining us. And thank you, Professor Athar Inam and Rashid Juma Sahab, for inviting me. It's always a pleasure. It feels like, even though we're not at AKU, but we are at AKU. So let me share my screen with you also. So please tell me when you have it.
Yes, we see it now. Thank you.
Okay, perfect. So we have 30 minutes. So the topic we've already mentioned. So the goal of the topic, you know, I'll give you 30 seconds of why I'm so much interested in this. And the reason I say this is that from 1999, I would say, till 2007, it was all an endoscopic surgery for me with ENT, always. You know, we were at Syracuse starting and initially at Minnesota also. But then when I went into practice, I could not find a good ENT surgeon. So I had to somehow switch to microscopic surgery. So I relearned myself how to do microscopic surgery. And now when I look back, I think that's the best thing that happened to me, because I think when you work between a microscope and endoscope, so as we move forward, I'll show you why I say that. So no financial disclosures. This is the main slide. I think this is something we all need to strive for. Is the voice okay? Am I too loud? Is it good?
It's perfect, sir. It's perfect. Yes.
Perfect.
Okay.
Yes.
So our mission is to have a comprehensive care. This is a paper out of neurosurgery, which talks about pituitary centers of excellence. And I think over time, people like Nelson Osiko, Ed Laws, who were the masters of microscopic surgery, have now switched over to, and including our friend Dan Kelly, have switched over now to endoscopic with ENT. So together, they do a lot of, most places are doing it now. So having a comprehensive care, education and training is I think the most important component to that. And of course, pituitary research. But if you look at this slide on this, I think this speaks for itself. Neurosurgery, ENT, radiation oncology, endocrinology. So when I moved to Pakistan in 2017, and I saw that all our young neurosurgeons are basically claiming to be neurosurgeons as well as endocrinologists also. They are intensivists, they are everything basically. So we started changing the mindset and we say, you know, I'm not going to be writing anything for endocrinology. all patients have to be seen by endocrine. They have to be seen by neuro-ophthalmology, just like I think you guys are already doing at Aga Khan also. So I think the paradigm is changing, and this is primarily for the patient safety. So is endoscopy better? My friend Atar Anam is an expert on microscopic excision. I'm sure Rashid Juma Saab has so much experience also. By the way, I didn't learn about this till, I would say 2010 or 11, when my friend and partner in New Jersey, Tom Steinke, who I owe. So every case of pituitary microscopic, I just started scrubbing with him in the first couple of years, because there was no ENT surgeon. And I think that was my learning curve from 2009 to 2011, I would say, how to do it. And since I was always thinking about coming to Pakistan, I wanted to do it without navigation, without just a C-arm, things like that, so that when you come to Pakistan. But now, mashallah, in Pakistan, we are doing everything what we do in US. So this is microscopic on the left. This is our team doing endoscopic. So this is the view, the difference which we see between endoscopy and microscopy. And this is the three-dimensional, or the endoscopes are mostly 2D over here, the view which gives us on the microscopy. So on the left is a microscopic view, on the right is an endoscopic view. Now this really fascinates me. The more I do, I somehow coming to Pakistan, there are weeks where we do 4 or 5 a week of these, right? Having 3 a day is not a big deal. So if I'm doing an endoscopic and we have 3 on the schedule, I would rather just do a microscope. And if I'll tell you what the cutoff is when I look at the imaging, because if you want to be done at a certain time, I think you can do a very good job with microscope also. It's faster, but I think the finesse and the results come with endoscopic. So moving forward, this is the view with the endoscopic view. You can see how the wide, you can see the planum, you can see the clivus, you can see all the lateral part, lateral cavernous. This is pre-op, this is post-op day 1. This is a very good paper I have always talked about. So evidence of improved surgical outcomes following endoscopy for non-functioning pituitary removal. So the tumor size gives away, this is where the difference really comes. And the literature in some of the trials has shown us that when the tumor is more than 2 centimeters, right? So it's already a macroadenoma, but especially if it's above 3 centimeters. So let me just remove this slide view. So endoscopic cohort, gross total resection 72%, microscopic GTR 50%. And higher rates of GTR for larger tumors, and the cutoff is 2 centimeters. In fact, 3 centimeters, there's a visible difference. This is a JNS paper from McLaughlin Group, Dan Kelly, talking about the endonasal. Let me see if I can remove this. Good. Okay, so tumor removal in I'm just trying to move this bar out of my way. Stop your screen sharing. Okay, so which talks about the stages of complications, right? So where we get most of the complications. So initially direct endonasal approach with speculum microscopy, maximal tumor resection under microscopic visualization, complete removal. This is all the steps which we go through by tumor size. Again, 2 centimeters plus, 3 centimeters for sure. The literature shows that there's an additional 36%, so more than a third, as the tumor size goes above 3 centimeters size. So on the left is the total size of the adenoma, on the right side are the adenomas which were done after the additional removal. So tumor size more than 2 centimeter, 54% additional advantage. And less than 2 centimeter, I think if the tumor is less than 2 centimeter, you can do a very good job between microscope as well as that. But most of the tumors, as we see here in our country and in this part of the world, are really, really large. So what are the advantages? Of course, better panoramic view, more detailed close-up view for high-def endoscopy, angle visualization, definitely better access laterally. As we go laterally to the cavernous sinus, suprasellar component of the tumor, and then there is definitely greater degree of removal and higher remission rates for functional adenomas. So goals of pituitary surgery. Of course, the goal is to remove the tumor, right? Eliminate the hypersecretion syndromes, then acromegaly, Cushing's. Cushing's are some of the tougher ones. Prolectinomas mostly are non-surgical now, but once in a while you end up operating on these. And of course, removing the mass effect, visual loss, headaches, you got to remove or take care of that. But preserving the pituitary gland function, in our opinion, is one of the most important things. If you've damaged the gland and you've removed the full tumor, I don't think that's a good job done for the patients. And lastly, complication avoidance. Again, complication avoidance. How we can avoid that, we'll talk about it as we go. So some of the outcomes already published: remission of acromegaly, this is the literature, in good hands, 70 to 80%, Cushing's, prolectinoma, resolution of visual deficits, hypopituitarism, headaches, all these are achievable, right? So complications, what are the complications which we encounter? So all these things, I always tell my patients, death can happen. Carotid artery injury can happen. New permanent deficit, definitely. New hypopituitarism, postoperative hematoma, post-op CSF leak. I think it's more than 1%, at least in our hands. Bacterial meningitis, rare, but can happen. So what are the stages of complication timeline? As we become more experienced in our journey in doing these, and how much volume we can get access to also. Of course, the patient selection and workup, experience with instrumentation, nasal sphenoid exposure, not very important part of the complication. I think the biggest complication timeline which happens is in this stage, which is the cellular exposure and the carotid artery localization. Tumor removal and gland preservation, less likely. You've already exposed it, and of course you can damage the gland, but if you're careful, you can preserve the endocrine function also. And of course, CSF leak repairs and skull base closure is the last step. So incorrect diagnosis or incorrect surgery, I think the best surgeons are those who know when not to operate. This is the main teaching thing I teach which was hammered into us also, starting from training. Morbidity of the sinonasal flora, as well as the errant trajectory, carotid artery injury, as we mentioned. Subtotal tumor removal is a complication. Pituitary gland damage, CSF leak and meningitis can happen, but how can we avoid that? So you got to know your opponent, right? What you're facing. You got to be realistic with your approach. How comfortable you are with the microscope, how comfortable with your endoscope. You got to be able to navigate. So having a neuronavigation, all of that is extremely important. But I'll be honest that coming to Pakistan and we do a lot of these now. So I think most of the cases we are doing are without navigation, without a C-arm. And the certain things which I have learned on my way, which I teach my team. There are 4 planes which you want to avoid and stay out of the carotid. You got to appreciate the gland. and always have an exit strategy. What we will do if something goes wrong, right? Incorrect diagnosis. Let's talk about this case. Now, this is a 22-year-old female with fatigue, headaches, galacturia, prolactin of 139. This is the tumor. You know, on first glance, we would say, okay, this is a prolactinoma, 139, yes. But when you look at this, I think this is a little bothersome. So this was missed by a lot of very senior people. So differential enhancement, it's homogeneously enhanced. There's no differential enhancement on this one. Here you can see the differential enhancement on a tumor as compared to that. So this turned out to be after two months of follow-up after initiation of therapy. So since we are this not a question and answer session right now because I'm the only one speaking, but this turned out to be by initiation of levothyroxine, so replacement of thyroxine. So this was primary hypopit with glandular hypertrophy. All the patient needed was thyroxine. So incorrect diagnosis, like I mentioned, this is, again, a very interesting case. Large, giant, cellular, supracellular, paracellular, you know, you can call all that. But this is not a surgical disease. This is a cabergoline. Dostonex has just done wonders to our patients. Again, like we say, the best surgery is no surgery. If you can manage it without surgery, why not, right? So the patient was treated medically. It's a giant prolactinoma. And this is the treatment result on medication. So now coming to the next is the trajectory. Now, if you're coming to this and you're trying to achieve on your C-arm, doing microscopy and all that, I think this is something which will get you into trouble. This will get you into the brainstem. You can see that, and this has happened. You can see damage to the brainstem on the right MRI post-op. So if you're not sure, use the tools. Navigation is excellent. I think if we could afford for every patient, we would do navigation on every patient, which we are still doing even in our now government sector, but not on pituitary cases mostly these days. So luxuries, of course, in US, we have all the tools just like we have them here now. You can do a combined approach also. But when you're exposing, if you have ENT, that's great. But if you're doing it yourself, which we are doing it now, most of the cases we are doing now are without ENT. What you want to preserve is this territory, SOS, right? This is basically the septal olfactory area, which is a strip. Preservation is extremely important, not just for smell, also eliminates the post-op epistaxis also. The bleeding is less, reduces anosmia, facilitates rapid healing of the nasal mucosa. So all these steps are something we want to achieve. So endonasal, this is the setup. I'm sure everybody is familiar with this. This is the key. You know, this is a two-surgeon, two-nostril. We do binasal, and it's a teamwork. It's not me doing the surgery. It's the entire team which is doing the surgery, right? So I think you want to have two monitors, preferably if possible, and 4 hands, 3 to 4 instruments. One holds the endoscope, one guides, one operates. This is exactly how we do surgery now, right? So, but this has been talked about for such a long time now. You know, most of the big centers have been doing it with ENT and neurosurgery, but in Pakistan, we are two. So our team is operating together with the 2 surgeons. And tunnel vision you want to avoid. Now, this is something which I think you want to expose as much laterally as possible safely. But tunnel vision is sometimes which is bothersome and which is dangerous. So suboptimal exposure, this is a good exposure. You can see laterally all of that up to the carotids. So the 4
Dr. Asif, you're mute. I'm sorry.
Somehow it muted me. Can you all hear me now?
Yes, sir. Yes, sir.
I think it's set up to mute after a certain amount of time. So the two curves on the carotids. So when you expose, you have the endoscope in there. So as you go laterally, you can see the curve laterally going around, right? That's where the carotid is on the lateral exposure. On superiorly, this is the planum. As the bone is curving up, that's where you need to stop. And inferiorly, the clivus, as it's curving down, that's where we want to stop. And I always recommend opening so removing the entire bony exposure, but we open up the dura inferiorly as possible to prevent CSF leakage. Okay, so large sphenoidotomy, sellar bone removal, we talked about, complication timeline. Again, sellar exposure and carotid injury, most worrisome. I have seen a couple, not done it myself yet. It has happened to us as our team, but we'll talk about it. So it's a never event. I think this is something you don't want to see in your so this is, let's see, a couple of videos which one of my partners has shared. This is let's see if it works. Yes. So you can see as we're exposing. So inadvertent cautery, Bovie, bipolar, I recommend not using a lot of this as we go lateral. So bloodbath, carotids, more onto the right side, which I could tell. Now, you can do anything. You can pack, you can do Surgiflow, you can do Flow-Seal, you can do, but this is something not controllable most of the time. I'm going to fast forward it because of time also. But now you can see it. It's right here, but what can you do? You can only pack, and then the next step, this is a board question, right? You have to pack and safely take the patient to the angio suite and try to see if we can, there may be a pseudoaneurysm by now, but you want to have the endovascular people take care of this. So I think we may have one more of this video. Yes, so this is another thing, you know, laterally as we're going, Kerrison ronger. So rongering is also something that gets you into trouble. So you're rongered and all of a sudden, so laterally you have to be very, very cautious. Respect the carotid. So again, packing and fortunately finding endovascular. And the debrider in the sphenoid sinus is also sometimes a significant issue. So dural opening over the carotid, you don't want to do that. Reasons for IC injury. I think the number one cause is getting lost. So as we're going in, I'm always looking, thinking about this, right? This is so you want clivus, you want to look at the carotid. You know where the carotid is between the two, right? Between the two curves. So if you're lost, go backwards, find the vomer, and then come backwards again. Find the clivus, look at the curve of the clivus, look at the carotid curves on the side, and then not knowing about the carotid location, not using navigation or Doppler. We don't use Doppler, we don't use navigation now. In US, we use all the time, but I think if you know the anatomy, you can stay out of trouble. So cautery, debrider in sphenoid sinus, you gotta be careful. Aggressive use of Kerrisons, cutting burrs, tumor forceps, all these are bad things. Potential catastrophes, wound punctures, lacerations, avulsions, pseudoaneurysms, vasospasm, subarachnoid, all these things can happen. It's uncommon rate, but I think it's underreported. And I have to be honest, since we started doing morbidity and mortality pre-COVID at PINS also, Punjab Institute, I think we have to be honest with ourselves and to our patients that we have to report them also. So the more cases you do, the less carotid injury you get. I think it's a learning curve. And this is all in literature. I found this. So 69 cases of carotid injury in some of the. This is a paper heavy with microscopic transsphenoidals, but all these things are real numbers. So ICA injury occurs fairly commonly. It's just not reported. This is what my take is on this. So again, anatomy. Cavernous sinus is separated, so let's not bore you with the anatomy. We're running a little tight on time, but let's move forward. Sphenoid sinus anatomy is extremely important. Rhoton's anatomy, the atlases, I think they are available on the AANS Atlas. They're free of charge. So all residents, all youngsters who are looking to get into this field should be paying attention to and doing this. So since we're doing a lot of redo cases also, I think those are the cases which can sometimes get you into trouble also. So as you expand, since we're talking just of pituitaries, but extra caution in patients who have had radiation and have been operated. And this is what I really think. You have to decide whether it's worth the risk to remove the cavernous sinus tumor. I think the best recommendation is to do if it's for visual loss, take care of that, do the optic chiasm decompression, remove the tumor and leave it in there. You can always radiosurgery it also. So essentials, navigation, Doppler, large bore suctions available. Just like we're clipping an aneurysm, you want to have one extra hand in available for suction. And then be prepared for CSF repair, muscle grafts, and aneurysm clip tray nearby. I don't know how much helpful that. I've not been able to do or help somebody once with an aneurysm clip, so it has to be endovascular to be realistic. Interventional radiology or neurosurgery interventional. So Doppler, of course, has, so this is what I was talking about. So this is the curve for the carotid. This is the curve on the right side, planum superiorly. And as you go down, this is the clivus curve. So as we move forward with carotid artery management, what if you have a rupture, right? We talked about it. Control, large bore suctions, pack it, find your interventional guys, find your neuroendovascular. So of course, ABCs, you gotta stabilize the patient, have good anesthesia, don't lose temper, don't lose anything, the patient safety is important. So as we move forward for the complications, tumor removal and gland preservation, subtotal tumor removal, gland damage, identify the gland. It is not easy. I'll be very honest, it's not easy to identify the gland, but I think as you do more and more of that and be more gentle, it becomes a little bit more doable. Removal macroadenomas, I think the larger the tumor, the easier it is. Like this one is just sitting at that. All you gotta do is get into the sphenoid and you're looking at the tumor. But the challenging part is the superior part that goes up superiorly. So at the end, you can do a Valsalva also, pseudocapsule dissection in adenomas. I think this is also a video. Let's see if we have the track. I'm going to move forward with that. So 3 months after removal of adenoma, imaging. Imaging is extremely important. Now I think more and more literature, just like primary tumors, we do gliomas and all that, postoperative day 1 or 2, post-op imaging is getting more weightage instead of repeating it at 3 months. So acromegaly with gigantism, these are also challenging cases, but I think more than that is let's see if there's a video on this one also. Okay, Cushing disease. So 56-year-old gentleman with weight gain, fatigue, libido decrease, muscle wasting, and bruising, cortisol level. So of course, has a small cortisol adenoma. So now this is a picture. It's tough to, this is from here, in fact. And it's tough. So you want to sit down with your neuroradiologist and see, because, you know, it's very, very difficult. Is this the adenoma or is this the adenoma, right? So you have to be, which side it is, you know, you need to do petrosal sinus sampling. All these things are very important when you're trying to localize which side the, so prolactinoma, unusual these days. Most of them are treated medically, but once in a while, you end up doing a prolactinoma also on who's had progressive visual loss, even on Dostinex and after 2 weeks of treatment. So invading the cavernous sinus, pretty common. It is not, especially in this, of course, getting involved with endocrine, preoperatively, postoperatively, this is always the key to get these to be managed with a multidisciplinary team with so post-op resolution of all these with surgery or a lot of times without surgery, prolactinomas. So moving forward. So improvement of the gland function. So most of them improve with time. The predictors of pituitary recovery, a lot of these factors are studied. So younger patients do better, lack of intraoperative CSF leak, lack of systemic hypertension. So these are, if you have had a damage of the pituitary gland, you know, these are some of the factors which will help you. Worsening glandular functioning, maximal tumor diameter, if it's a large tumor. Older patients don't do well if you damage the gland. Endocrine inactive tumors, those are also sometimes difficult to. So as we go up on the size of the tumor, I think the failure also increases for the gland. So again, conclusions, functional preservation of the gland as much possible. Majority of pituitary adenomas, you want to have that risk of new hypopituitarism increases with tumor size. 2 centimeter is the threshold, and pre-op identification of the gland. So always, you know, we don't get to do it this much here, but I think sitting with neuroradiology and reviewing all these, especially when you're starting out or early part, is extremely, extremely important, especially when you're doing pushings or one of those where you have to look for it. So, so post-op monitoring, again, endocrine involvement, adrenal insufficiencies, all these have to be basically having the intensive care as well as the teams with your, and a lot of times we're doing this now with ENT. So if you have a good ENT available, I think this becomes much more. I think since we're doing so much other stuff also in practice, this is the best way of dealing with these. So find an ENT good surgeon who's willing to work with you, and CSF leaks and all these, I think, are better managed with your good ENT colleagues with endoscopic experience. So since we are not talking about endoscopic CSF leaks in this talk, so of course, graded repair protocol, diaphragma cell location, as well as the, like I mentioned initially, limit, try to open the dura as low as possible, leave shelf of bone along the floor if possible. These are some of the tricks to stay away from, and always have be ready for a fat graft, and consider selling for with dead space with fat after you remove it, and always get a Valsalva maneuver to see if there's any leaking of fluid which can happen later on. So all of these buttress, you know, the different types of how you can repair CSF leaks and all that. I think that's a different topic. We can talk about this. In Pakistan, I would love to have all of these TCL, Duracell, but then you got to look at, you know, what affordability issues and all that, because the patients are paying from their own pocket here. So best is if you can stay away from a CSF leak, that's the best option. And then some medical Diamox, lumbar drain placement, if you have a large tumor, if it's more than 3 centimeter and you're expecting a CSF leak, just do a nasoseptal flap and have a drain placed also preoperatively. So some of the graded repair protocols, TIL test prior to discharge, common sense. I'm sure everybody does that. Grade 1 leaks, different types of leaks. I'm going to skip some of these forward as I think we are getting beyond the, in the CSF leak section also, I think this is, I don't know, I've never done with the microscope, it's for leak, CSF leaks, endoscopic leak repair is the predominant mainstay, and working with the ENT, of course, like I mentioned, HD endoscopy helps, preservation of nasal mucosa. So as we conclude our topic, again, clear glandular location, graded repair, and low rate of and preservation of the anatomy. I think those are all the keys which we should be able to use. Again, anatomy. You should be knowing where you are. Team approach, at the end, I'm going to say this again, neurosurgery, this is a team effort. This is not Asif Bashir or Athar Anam operating. I think it should be ENT, all the team, endocrine, all of them have to be involved. I think without that, we cannot change the paradigm. And if this was any of our family members, I think this is what we would want for our patients. Okay, great. I hope this was a good overview of the topic we had agreed to talk about.
Thank you so much, Dr. Asif, for such an excellent talk. Now I would like to invite Dr. Athar for his comments.
Thank you, Asif. Yeah, this is perfect. So we have enough time for a lot of discussion and question. And as you and I, as we have discussed in the past, this webinar series is basically for all of us in Pakistan and beyond. We get tired from the webinars and lectures. Here is where we find discussion and making it more interesting. And there is nobody who can carry out a better discussion than Dr. Juma. Professor Juma, he has that intellect that he can ask the right questions, give the right answers. So Dr. Juma, can I pass the baton on to you? We have Dr. Irfan Yusuf and other neurosurgeons, Dr. Saad Akhtar Khan also. You can join in the discussion. Let's keep the discussion all academic, and opinions are welcome. Dr. Juma.
So Asif, thank you for this talk, and it was a total overview and a romp through the field in its entirety. But when you speak about practice in Pakistan, you mentioned that the tumors are large. And so in Pakistan, pituitary surgery, by and large, is for visual failure. And so I think that it may be helpful to have you speak to your experience with visual outcomes of your practice in Lahore, and how you think and what you think are the ways in which we could perhaps be doing better for that, if it's possible at all. Because a lot of the patients actually present very late, and however good decompression you get, perhaps is not enough. But I think the critical question that I want you to share your thoughts on are visual outcomes in these people with large tumors that are severely impacting the chiasm. Asif?
Thank you. So Rishi, you're very right. I think my thinking, my approach I think I've also learned a lot of things by coming back to Pakistan. And that the number one thing is the volumes. When you end up doing 3, sometimes, initially we were doing 3 a day, it'd be done by 2 p.m., right, in the morning. So that's when I thought initially we were doing more of microscopic, and most of them, like you mentioned, are there for visual deterioration, right? Blindness, bitemporal heminopsia. And since in Pakistan, and I'm sure it's the same in Karachi also, in Lahore, they are coming at a very late stage. So if they've developed optic atrophy, if they're bitemporal heminopsia, I would say most of them would have some benefit, but a fair number of them would not improve. So anything which you can do as safely as possible, that is what my teaching is, or this is what I recommend. And I'm a big fan of microscope also. And when I moved back here, we were initially, even at LGH, using both. I was using, if you have more than 2 cases, you would do a microscope, and decision of the case is also done first because of the presentation, like if it's optic chiasm compression, and then also the size. If it's a large tumor, you might as well just decompress and get away, and then and see if it improves. You don't need to be very, very aggressive, give endocrine issues to the patient. And then you can stage it. You can always, if the patient, a lot of times the suprasellar part will sag, and the second surgery should always be a transsphenoidal one, endonasal, right? If it sags down. So visual improvement is pretty significant, but if they have delayed it for a long time, if they developed atrophy and all that, I'm sure it's the same with all of you, then it is very difficult for them to get good, meaningful vision if it's already been such chronic damage.
Dr. Farhan Mirza is joining from Kentucky, USA. So Asif, do you know about Farhan, right? Farhan is an AQ graduate, did his residency in Kentucky, and then he was in Montreal, did epilepsy surgery fellowship back in Kentucky. So Farhan, what are your thoughts about the proportion of endoscopic versus microscopic in Kentucky? You're mute, Farhan. Yes, sir. Yeah.
Thank you, Dr. Azhar, and Assalamu alaikum, everybody. Dr. Bashir, thank you for a very nice overview of the topic. My experience has been 100% endoscopic. I have not done any microscopic. I think the last microscopic I saw was with Dr. Anam when I was a medical student at AKU. I haven't seen one since. A few things that we do over here, and Dr. Bashir, I would like you to comment on that. So the use of an endoscope holder. That frees up let's say if you don't have an assistant surgeon or you don't have an able assistant who can drive the endoscope for you, using that endoscope holder can be a very nice adjunct, and the field is stable and you can humor with that. We always use an ultrasound, even if we don't have navigation, which is almost never the case. We always have a Doppler to map out the carotid arteries. I personally have not experienced a carotid injury, but I've read about it. I've seen videos of it. My understanding is that you should not be using any flowable hemostatic agents, Surgiflow or Flow-Seal, because that can embolize distally and cause a problem, but rather use either a quick muscle patch or put lots of gel foam on there or a cotton patty and blow up a Foley catheter to compress and then finish the operation and go to the endovascular suite. So those are some of the observations and comments I have about this. I think an additional thing which any surgeon starting out and wants to do this, they have to really understand how to do good closure at the end. And the key to a good closure is small bony opening that is as big as you need it to do the operation, but not a humongous opening that you can't close it at the end. We use fascia lata graft a lot to use as an inlay graft followed by an artificial bone like Medpor. I know those are limitations from a cost standpoint in a setting of Pakistan. But fascia lata graft works nicely for us. Durapair or Alloderm, those things have worked nicely for us. But a gasket seal closure for larger tumors with CSF leak. And then obviously, as you mentioned, lumbar drain. So those are some of my thoughts and comments on this.
Thank you. Asif, do you want to put any counter recommendation?
So
Otherwise,
Farhan,
we can go to a phone business also. Yeah. Okay, go ahead.
I'll just give my experience. So as Farhan said, so I have the privileges of being in both worlds. So now I operate in US also every 3-4 months. So when I go back, that revives all the stuff which you can just get without having to ask for it, right? Everything is all set up when you walk in. You don't need to worry about anything. Mm-hmm. Now the Greenberg retractor, the other types of retractors, we've used all these, I would say, a long time ago. And I think if you can find somebody, even a good resident, somebody to hold that, the problem with the retractor, and some people are comfortable with that. I've seen most surgeons, of course, I don't just speak for myself, but most people, friends and colleagues who do a lot of these, they've stopped using the handheld, the self-rotating thing, because I think you got to keep on moving it, when you have to, and then every time you move the scope out to clean it and all that. So that's it. I think it's, and we also just keep on irrigating at the same time. So that's our take on it. Secondly, we are using binasal, so endoscope is on one side, so you can irrigate and work on the other side. Surgiflow to seal, I have never used. I think I had a few when I came to Pakistan, so nobody can find it. But in a complication like carotid injury, which I have not had myself, but we were able to help. It has happened to us in our team. I think that the mainstay is to get to the angio suite. That is, you got to pack. It doesn't matter what you're putting inside muscle. It's not going to. You have to be able to get an angiogram, and because a lot of times there'll be a pseudoaneurysm also, so you have to manage it. And Farhan, what was your last point? You had mentioned about one more thing. After
CSF leak repair.
CSF leak repair, yes. So fascia lata. So we don't do a nasoseptal flap now for anything which is I would say 2.5 centimeter, right? A lot of times you can fascia lata is definitely, so fat. In my opinion, fat doesn't work. You have to have fascia lata. So and then with the gasket. But if it's a large tumor, you already know, or if it's too suprasellar, you have to go superiorly. Then you want to prepare the nasoseptal flap. And I'm sure like Farhan is using, I never saw an endoscope till about 2000, microscope. It's all endoscopy in US. So I think somebody out with a microscope, but of course I showed you the magnifications, the views. Endoscope is superior in most cases to be able to get the visualization.
Thank you.
Yes.
Dr. Juma. Well, Dr. Juma, we can ask Dr. Irfan.
Well, I just want to ask Farhan, are you in the cockpit of your private jet, or is that
right.
just how your living room looks?
That's exactly right. It's a cockpit of my 2010 Honda Accord. Yes, that's right.
Oh, I see. Okay. All right.
Okay, Dr. Irfan Yusuf, are you going to say something?
Assalamu alaikum, and thank you, Asif, for your excellent presentation.
Dr. Irfan Yusuf is a surgeon at Shaukat Khanum. Excellent, Irfan. Excellent. Dr. Irfan Yusuf is a neurosurgeon at Shaukat Khanum. He was trained in Ireland, and he has been at Shaukat Khanum for about 5 years now, Irfan?
That's right, yeah.
Irfan, you've been... Yeah, okay.
Can you hear me?
All right. So go ahead, please.
So, thank you very much, Asif, for your excellent presentation. And certainly it covered all aspects of pituitary surgery. And as Professor Juma mentioned, we are in Pakistan, and it's a whole new ball game when we come back. So having worked in Ireland, I had the opportunity of working with the surgeons who were totally committed to endoscopic and other surgeons who were doing microscopic, especially the sublabial approach. And both were having, fairly good results. So it's a matter of, training plus getting on to using new techniques. So when I came back, certainly it was a new setup and we were getting instruments, and certainly we got the setup here. Endoscopic surgery, where I trained, surgeons were routinely using the Axiom navigation, which was useful in the sense that the head doesn't have to be fixed. And the ENT surgeons are on standby, getting you through to the cellar floor where the neurosurgeons will take over. So certainly I use Axiom, get the help of an ENT surgeon. That takes a little bit of work off my shoulders, being as, the only in-house neurosurgeon working full-time. The pressure gets on. So that is the reason ENT surgeons will help. Certainly they know more about the anatomy and the approach. Having said that, there are surgeons in Ireland who will do the procedure themselves with complete exposure, going all the way in and then dealing with the complications if they do happen. So it's a matter of how much we would like to take it on our shoulders in terms of the approach and then dealing with the CSF leak if it happens. So coming back to what Professor Juma mentioned, and as you mentioned as well, and I'm sure Dr. Athar will concur, we have patients who present after 3 years, 2 years, already have lost one vision in one eye, and then there's a hemianopia on the other side. And the ophthalmology review is important. We tend to get documentation pre-op by the ophthalmologist whether there is optic atrophy. If that is there, then we have to counsel the patient. Whatever we do, the vision may not improve. If it does, it is going to be a bonus. Certainly with patients having hemianopia, there's greater chance that the visual field will improve. And in terms of acuity, it is difficult to say depending on how bad the optic atrophy is. So that is my take on the visual improvement. With large tumors, so far as the approach is concerned, it's standard. But what I have learned is that using a 30-degree or even a 45-degree scope towards the end of the operation, one can look up into the lateral recesses as well as in the posterior recess, especially if the diaphragma cell has descended. One can push it up and then look for certain remnants that are difficult to see with a 0-degree scope. So that's where I found that the endoscopic approach will actually help dealing with large tumors. Thanks.
Great. Dr. Juma, आप कुछ कह रहे थे when I asked Irfan to.
We have a question, sir, from Dr. Waqas.
Right. Dr. Waqas का question है, Dr. Sarmat का भी question था, और Dr. Altaf कुछ कहना चाह रहे थे. Altaf, you had something to. You were saying something.
Yes, I had a same question which Waqas has just mentioned, that what kind of preparation you make when you are doing redo surgery, and what are the difficulties you anticipate when you know that it's a redo surgery, especially post-radiation? Do you still use endoscope? So this is my first question. The second question is, usually what happens when you are using endoscope and there is a vascular injury, there is a gush of blood, and that obscures everything. Then what is your knee-jerk reflex immediately when this happens? This is from panel, from discussion. Anybody?
So let me answer the second question first. So the answer to the blood bath is that you can do anything. You can have aneurysm clips available. You can be the best vascular surgeon. You have to try to get the bleeding packed, because if the way the bleeding is happening, with the endoscope, you cannot keep it inside.
The vascular the clip, how can you put the clip in there? I can't understand.
That's what I'm saying. There are a lot of surgeons, so that's why I said I've never had the luxury to be able to do anything with an aneurysm clip. Allah na kare. So, lekin jab nazari, when you're not able to see, so you have to pack it up. And endoscope is not a good instrument when you have this blood bath. There, I think a microscope is more handy. If you're in a situation like that. So, and then, you know, next doors, go to the endovascular is next door. So we end up, if such a thing happened, we know we would go there.
But I think Altaf, a question ye hai ki agar vascular injury ho jati hai, it's all endoscopic, you don't have time to drape the microscope and bring it in. So you have to deal with it endoscopically, right?
Endoscopic.
And,
so
if there's a word blood bath that you're using, so, you know, once it's there, so all you can do is just pack it and, you know, put suction on it, exactly. And, right? Nothing else.
That's all you can do. You have to pack it, and you have to take the patient to the endovascular suite. There's no other option, in my opinion.
Dr. Juma, aapka kya khayal hai? Dr. Juma?
So,
Dr. Juma.
Fortunately, I've only had 2 events, and both events were subsequently fixed by endovascular. One patient was shifted from JPMC to Tanveer, and the other one was in AQ. Experience, what I can say to you is that carotid is a terrible thing to injure, but the good thing is that you're in an enclosed compartment, and packing actually is pretty effective. The pressure of carotid blood is just horrible, but when you're in the cavernous, when you're in the sphenoid sinus, the bony walls help you, and so packing is really just the only way to go, and it's pretty effective. So, you know, but I think that you made the point more than once. The best way to manage is to avoid it happening. So that's my
and look at the anatomy. So the first question, Dr. Saab, you were asking about redo cases, right? So yes, we do them. So I'm doing all cases right now endoscopically, right? So for last almost 2 years now. But initially, for the first year, I was using microscope, and, you know, now we just do, instead of doing 3 in a day, you know, you just spend, and it takes, on a good endoscopic case, I'm not going to say how fast we are or not. It's going to take you about 3 hours. Okay, so let's be honest. You can do, if you have multiple rooms running, you can do 3 microscopic cases in that hour just for optic chiasm decompression. This is our experience. Now, the way we do it, our teams, the senior registrar / assistant professor, all are getting 4 months of endoscopic experience now. All of them go through this, they rotate it, we all do our own exposures, they're all doing exposures. And of course, we're there to bail them out, and all CSF leaks. So this is how we have crafted the program here, at least in our unit. This is how we're moving. And mashallah, I think, except once or twice, we've had complications. So and I have not faced it myself, but I have helped 2 cases with the carotid injury. That's why I say it is not pleasant. And when you go in, what else do I end up doing except packing and taking the patient to the endovascular suite? Because you cannot see in the, coming back to the redo cases, anatomy is the key. You don't know so always have good imaging beforehand. Always get a CT also. CT, you know, like a FES CT, you want to get that, as well as a skull-based pituitary with a protocol to look at the anatomy of your bones, because we don't know what has been removed before that. Again, with an endoscope.
Asif, there are a few questions.
Ji, go ahead.
Asif, you know, there are a few questions. 7 baj gaye hain, but then people are just coming in and they don't want to leave. There's something.
Okay, we can carry on.
You know about. Yeah, something about you. So जिसको जाना वो चला जाए, लेकिन you know, Asif, we're gonna hold you here, buddy.
And I want to tell you one thing.
Answer some of the questions very quickly.
We will do that. But what I want to say is that Athar and I have been talking about this thing. I think instead of having all these webinars which are going on, this is more important, what we're doing now. I see more than 80 people sitting there. I can come and brag about what I do all the time, right? But it is what we want to hear from you and how we interact with all of you and see. This is where the learning is, right?
Absolutely.
So I think what Atar has done is amazing. I think this is great. This is going to expand.
Absolutely. So Asif, couple of questions. Then there was a hand up by Dr. Iqbal wo niche ho gaya haath. So ek to Waqas, he's a final year resident. So he asked, how do you feel about redo surgeries endoscopically? For example, if biochemical cure is not achieved after surgery for Cushing's. So hum chote answer denge Waqas sab taki we answer everyone. Ji, Asif.
Okay.
So what's the question? The redo. So what's your take on redo surgery, right? So redo, I mentioned.
Yes, sir. So basically, I wanted to ask if do you find any difficulty while doing redo surgeries, or is it just the same for you? I mean,
I'll be very honest. Pakistan mein jo hai na, we end up being the redo surgery anyways, right? So even spine ki bhi redos hi hum zyada karte hain. And the more endoscope you use, spine maybe we do microendoscopically. I think that is the key. You want to find the normal anatomy, right? Just like in spine, you want to go more lateral and come medial. This is what I do in endoscopic pituitary. Always find your vomer, find your midline, and then have navigation available. If you're doing redo, always have navigation. I think that's the key over here. And Cushing's and all that, I think the cases we've done a couple of cases recently, and Atar has also done, because we have common patients we now interact with. So Cushing's and all these are always redo, because they're coming to us because pehli baar kaam pura nahi hua. So they are challenging. You just have to be patient. And as long as you're not going too lateral, carotid is the only thing I worry about, right? CSF leak is not a big deal. So be patient, look for it, have navigation, know where what you're looking for. That's the key. Next.
Right.
Next question.
Dr. Iqbal also has a question.
Dr. Iqbal Ahmed. Dr. Iqbal, do you want to ask yourself the question? Iqbal Ahmed. Okay, well, I thought his hand was raised.
Yes, he was raising his hand, but I cannot see him now, sir. So Dr. Irfan has a question.
Maybe he's left. His question was, what is the age limit of endonasal pituitary surgery? That was his question. And he's here. Dr. Iqbal is here.
Yes, very nice presentation. So is there any age limit for endonasal surgery?
Dr. Iqbal, आप अपने आप को introduce करा दीजिए. बहुत बड़ा group नहीं है ये. You know. So
yes, sir. I'm assistant professor of neurosurgery at DG Khan Medical College, Dera Ghazi Khan.
Mashallah. Good. You know, एक और भी DG Khan का बंदा बैठा हुआ यहाँ पर. There's another DG Khan guy in here. You know that, Dr. Iqbal. Dr. Iqbal, there's another DG Khan guy here. You know that. So Ahsan Ali Khan is from DG Khan. Chale.
Oh, yes.
So Dr. Iqbal's guess was Dr. Altaf is from DG Khan, sir.
Asif, jawab de, please.
So they can we can look up literature, but experience-wise, when you do endoscope, when you're doing pituitary surgery, you know, it is common things are common. I can tell you with my experience, bachon mein, I have never done a pituitary, right? It is very, very uncommon to have that. So, but the cartilage and all of that, I think they are not very, anatomy is not very well developed in children. But I would say anything above 8 or 10 years, it should be fine. Because majority cases, even in younger, acromegaly and all that, you can have teenagers. But I have yet to operate on somebody who's less than 10 years old.
Right.
Thank you.
But
then Dr.
Saad Akhtar is raising his hand. I will ask him to answer.
Saad, please. Aap introduce kar diye, Saad, boliye, please.
Great talk, Dr. Asif. Dr. Saad, I'm assistant professor at Liaquat National and also working in Afan University Hospital. So, what limited experience I have...
बताया कि आप आखान यूनिवर्सिटी हॉस्पिटल का ठप्पा है. Yeah, I mean,
sorry sir,
you are a proud graduate. भूल ही गए, देखो ना, ये अपने पास्ट को भूल जाते हैं लोग कभी कभी.
नहीं sir, I was
अच्छा बोले.
He mentioned it.
Saad, go ahead.
So basically,
he mentioned he's also a faculty at Al Khan. अच्छा चले, sorry Saad, आगे चले हैं please. I was just joking.
Basically, how I was trained was a combination of microscope and endoscope, mostly microscope. So when I started doing pituitaries, microscopic plus endoscopic, the fear of injuring the carotid was so much कि हम lateral इतना नहीं जाते थे. But you would as a young neurosurgeon, मुझे लगता था, मेरी tendency है कि I would be navigation नहीं होती थी, but my tendency was कि plenum की तरफ ज़्यादा चले जाएं, clivus की तरफ. So I think when you start doing pituitaries, you're so afraid of injuring the carotid that आप lateral तो इतना नहीं जाते, and then the bony opening that you make is just enough कि आपका ring that you can engage the ring curate. So how important is an adequate bony opening? Because when I started, I was just opening, doing enough bony opening so that I can engage a ring curate. And when I started, I think lateral se zyada jo issue tha without navigation, I was more towards either towards the plenum or towards the clivus, because you have vomer and then sphenoid sinus ka septum, that gives you an orientation of the midline. जो ऊपर और नीचे की orientation होती है without navigation, I think that's more difficult when you start.
So like I showed you the video, एक मैंने picture आपको दिखाया था बीच में Asad. So therefore, so this is how I was taught, and I think over the years, like I mentioned, when I started off, and I used to operate with my partner, अभी भी मैं करता हूँ. Tom and I operate all the time when I'm there. I think he's one of the most aggressive surgeons, and which has showed me the limits, how far. So the two curves of the carotid we want to see. And when you go laterally, the planum superiorly jana se zyada inferior clivus ka zyada important hai, because planum mein to the higher you go, the more chances of your opening the dura and getting a CSF leak also. So the lower you go next to the clivus, that's where you want to open it. Laterally, if you just want to put a ring curate and all that, I think you're doing not a satisfactory job. My take on it. So if you go lateral, you will know that you're getting into trouble as the bleeding thodi karke, venous bleeding and oozing बढ़ती as you go towards the cavernous sinus, right? You don't want to go to the cavernous. You don't need to be exposing the cavernous carotid, but you want to be getting where you can see that curve laterally. So you have a good exposure, and it's the same with the microscope. There's no difference in the उसमें speculum डाला और उसको आपने side पे किया, and you're all the way down to the. So I think microscopic is quicker if you want to do it, but having a good exposure is important. This is my recommendation.
Dr. Irfan, और फिर उसके बाद एक और question लेंगे Dr. Fatima का. जी Dr. Irfan, you were commenting something about the fibrous.
Yes, I read about it, but whatever experience I have, it's not a huge experience. I've probably just come across one or two patients where using the curate didn't really produce the desired results. And I could actually feel that and see through the endoscope strands of tissue that are actually difficult to curate. And one has a tendency of, grasping them and pulling them down. So I just want to get your experience, Professor Juma, yourself, Dr. Asif, and other people here on the network. What is your experience in terms of really encountering a truly fibrous adenoma and how to deal with it?
I thought you want to answer, you want me to answer?
Well, I mean, fibrous का अंदाजा अभी हम लोग जनरल क्लब भी कर रहे थे इसी चीज पर recently, right? Fibrous का अंदाजा तो होना बड़ा मुश्किल होता है preoperatively. Once you go in there, you are stuck with that tumor. And I've ended up in a lawsuit actually because of fibrous, and so it's a tough thing to do. I would rather abandon that case, just maybe take a biopsy and to confirm what it is, and think of some other options on that one.
Right, because what the only fibrous or so to say, difficult to create tumor that I encountered was actually a pituitoma, not an adenoma. And, we really couldn't tell whether this was an adenoma or a pituitoma. And the result came back as a pituitoma. And certainly that explained why it was so difficult to correct and remove. So we just took a biopsy, certainly, of that tumor.
Right.
We left it.
I think that's the right thing to do. Just take a biopsy and then look. That patient that I mentioned, ended up in USA, and they again attempted it with a CUSA and everything, and again he had more complications, and that he went on a vent for a while in the ICU over there. So that's a bad disease if it's fibrous, if it's hard. What's your thought, Farhan, on that one? Yeah.
If it's fibrous and if it's not coming, just leave it.
Just leave it. Just but then take a biopsy to confirm it, right?
Right. Of course. Right. Yeah. But don't go after it. Yeah.
Asif, there is another question, and that's the last question probably. Then Dr. Hassan will close. It's Dr. Fatma, year 5 resident, AQH. Would a combined approach with micro and endoscope will help in time management? I've seen some surgeons using endoscope only at the end for lateral extension of the tumor.
So Fatma, that's a good question. We've used it just to show the residents and all of that, the difference initially. I think, like I say, microscope is good as long as you're doing 2 centimeter. That's what the literature has also showed us, right? But at the end, because we use 0 degree for most tumors, right? And if you want to look up and go up, then you can put a 30 degrees. I would say in most pituitary tumors, you can just manage with a 0 degree. You don't need anything fancy on that. But you can put a microscope, you put your speculum in, and then as you're getting comfortable, you can put your endoscope inside. That's going to limit your movement of your endoscope for sure, right? As you're going in, because now the speculum is there. You can add if you want to look. So I think one of the questions was coming, Hubia Khan Waja, the person who's working at Liaquat National, was that he was scared of going laterally. So why would you be scared of going laterally? As long as you're not doing anything, endoscope to leke, you can go for a ride, you can look around. So as long as you're not using a Bovie, bipolar, anything in there, and so you can look around the anatomy. So just be comfortable with that. This is the first key of using an endoscope to get an idea, get a feel of the, and then just once you are getting comfortable with the anatomy, again the 2 carotid curves, planum superiorly, clivus niche. This is it. This is all about. This is where you want to stay within that. So you can try with the microscopic initially and then put an endoscope and get comfortable with it. But don't be afraid of it. I think endoscope is a very fairly safe instrument.
All right. Thank you, sir. So I would like to ask Dr. Juma if he has
We can't ignore, Farhan Mirza from USA. I mean, we can't do that. Farhan, what's your question is? How difficult or costly is it to get a Doppler, especially when navigation is costly or not available? Doppler can make a big difference. We can buy. We have to buy a special Doppler. For the other Dopplers that we use,
I'll answer this question.
Feasible for, yeah.
So Farhan, that's a good question. I was doing a Moya a couple of weeks ago in the private sector. So I asked all my cardiac surgeons, बाकियों को भी मैंने कहा भी Doppler तो बताओ कौन सा use करना है vascular. सरकारी को तो भूल जाते हैं. So they all came up. They sent me the picture of the same Doppler which I was going to be using also. So when we tried to use it, that you cannot even take it. Forget about the nose, right? I'm talking about either a carotid Doppler or because we do carotid endarts and all that also. But just on the scalp, it is very tough to even sterilize that and bring it on that. So we just did it without that, just with your finger feel and all that. So as Farhan, Pakistan mein aur chakkar lagega from Kentucky, you'll realize how many things we can do without a lot of toys which we have in US. So this is what
लेकिन मजे की बात ये है, डॉक्टर बशीर, मजे की बात ये है
मिलता सब कुछ है यहाँ.
Yeah, exactly. Navigation pe, लाखों करोड़ों रुपए खर्च हो रहे हैं. Doppler would probably be, a much less pricey option. And it actually might be more beneficial that Doppler is available ho, and people use that to avoid micro Doppler that goes through the nose. Yeah.
So the thing is that the Doppler जो है ना जो हम लोग इस्तेमाल करते हैं अक्सर क्रेनियोटमी में वो तो इस्तेमाल होना मुश्किल है. So you have to buy another micro Doppler. Whereas the navigation is already present there. So you know उसका कोई extra charge नहीं navigation का. But macro Doppler का extra charge है. But having said that, yes, one can obtain it. And again, having said that, I can tell you that I just go by either visual navigation or the this neuro navigation system, and that lateral is not an issue unless it's going into the sinuses. But carotids ka masla nahi hota hai itna. As long as you keep anatomy, and that's what Asif has been saying: anatomy,
exactly.
Athar, last question to you now. If I have the liberty to ask, so Athar and Juma Sahab have so much experience on doing it with the microscope. Now, when you do it, do you do a CM also? Lete hain CM?
No, I don't do CM.
You just do it and you look at the anatomy.
I just look at the anatomy and
I think that's very reasonable. But initially starting out, to all the youngsters, if you're using a microscope, you have to use a CM because usme aapne speculum dala hua, you don't know where you are. You can be lost.
Oh, that can be a disaster, right? Saad, why did you ask the question now? We can't close it. I mean, we respect you so much. So pneumatization of sella, does it make a difference in your approach?
Dr. Saad is double consultant.
Huh? Dr. Saad chalega kya?
Yes. Dr. Saad को सर unmute कर देते हैं. The consultant.
नहीं, Dr. Saad ने सवाल पूछ लिया ना, ये अब सवाल तो जवाब देंगे आसिफ.
What's the question, please? दोबारा बताएं.
Pneumatization of sella, does it make a difference in your approach?
It doesn't really matter because you are approaching it regardless of, you're using an endoscope or a microscope. Aapne jana, you have to find your anatomy and then go forward. So the job has to be done. But do add I would totally agree with Farhan. There's no excuse for us not to have a micro Doppler. There's no excuse. If we have, even in the Sarkari setups, we have stealths, just like the other Khan and I know Shaukat Khanam also has it. So why can't we have a micro Doppler also? So use the tools what we have. It doesn't take more than 10-15 minutes to set it up.
Thank you, sir. So I would have asked for the final remarks from Dr. Athar and Dr. Juma, but I think Dr. Saad and Dr. Farhan has taken that time. So I would like to thank you all.
But this was great. Yeah, wonderful. Thank you.
Thank you, Dr. Asif. Thank you, Dr. Athar, Dr. Irfan, Dr. Juma, Dr. Farhan, Dr. Altaf, joining us. And hope to see you all after 2 weeks, inshallah. Take care and have a good weekend. Thank you.
Thank you.